Hello, and welcome to our evidence based practice group project by Group 3, including Ruby, Mosin, Rachel, Jennifer, and Josh. For the clinical problem and clinical question section of the presentation, our group collaborated and decided that we would tailor our research in this presentation to the ICU department, and more specifically, looking at um, a very sad and painful experience of ICU patients when they experience pressure injuries. So, pressure injuries, um, the problem is critically ill patients in the intensive care unit are at a high risk for developing these pressure injuries from immobility, hemodynamic instability, reduced sensory perception, inadequate tissue perfusion, and prolonged use of various forms of devices in the ICU. So, despite the use of standard prevention measures such as repositioning schedules, pressure relieving surfaces, and multiple skin assessments of shift, pressure injuries continue to occur at a heightened rate, leading to increased pain, infection risk, length of stay in the hospital and ICU, and overall healthcare costs, which can be a burden. So, because current strategies alone are not always sufficient, there is a need to explore additional non invasive, low risk interventions such as effleurage massage. This can significantly improve tissue perfusion, skin integrity, and help reduce the development or severity of pressure injuries in ICU patients. So, for our Peacock question, as a group, we narrowed it down to in critically ill ICU patients, does the addition of effleurage massage to standard pressure injury prevention measures compared with standard measures alone reduce the incidence or severity of pressure injuries during the ICU stay for the patient? So, to answer that, we will continue on in our presentation.
On this slide, I'm introducing the overall body of research that explores whether massage, specifically the effleurage technique, can help prevent pressure injuries in ICU patients. Pressure injury prevention is a critical component of nursing care in high acuity settings, and because ICU patients are often immobile, they are at higher risk for skin breakdown. According to the randomized control trial, in 2025, the research base on massage for pressure injury prevention is still somewhat limited, but it is growing and increasingly promising. Their work highlights that although massage is not currently a standard guideline recommendation practice for preventing pressure injuries, emerging studies are showing potential beneficial effects. So this slide sets the stage. There's interest in massage as a low risk, non pharmacological intervention, but evidence has historically been mixed and somewhat sparse. This new RCT helps straighten the growing evidence. Here I'm reviewing what the broader research synthesis and individual studies have found. First, international pressure injuries guidelines do not recommend massage on bony prominences because of concerns about shear force. But even with that caution, multiple reviews and descriptive studies show that nurses believe massage may help prevent pressure injuries. A major uh, Cochrane review has also found that while massage can improve circulation and skin hydration, the evidence was not yet strong enough to support a formal recommendation. Next, several individual studies do show benefits. For example, olive oil massage reduced pressure injuries incidence by 50% in ICU patients. Almond oil massage significantly decreased pressure injury development compared with controls. Coconut oil applications also show protective effects for immobile patients. Even compressed air massage has been shown to support healing in diabetic foot wounds with which suggests massage stimulates beneficial blood flow. Together, these findings suggest that massage, especially when paired with moisturizing agents, may support tissue integrity and delay breakdown. So, although guidelines haven't officially endorsed it, the evidence base is trending positively. This final slide focuses on the most recent and strongest level of evidence. The randomized control trial conducted by Elzakar and Klinger in 2025, which is primarily a research article our group selected. In this study, ICU patients in the intervention group received a 15-minute effleurage massage twice a day in addition to a standard nursing care. The results were significant. Only 26.7% of the massage group developed a stage 1 pressure injury, compared with 73.3% in the control group. The massage group developed pressure injuries later, on average around day 8, while the control group developed them around day 4. And overall, the massage group remained pressure injury free for a longer period, averaging almost 11 days, compared with about 7 days in the control group. This strongly suggests that gentle effleurage can safely enhance circulation and protect tissue without causing friction or shear. So, in summary, the research landscape shows a small but meaningful evidence base supporting massage as a complementary stage in pressure injury prevention. It also highlights that more studies are needed to determine the best pressure, duration, and frequency, but the direction of evidence is promising. This RCT straightens the argument that massage could be integrated into practice as part of a comprehensive prevention approach.
So when it comes to the knowns and unknowns, what we know is that ICU patients are at very high risk for pressure injuries just due to the immobility, perfusion problems, and the intensity of the invasive care. Current prevention is helpful, but it's not efficient. Um, and despite repositioning and specialty surfaces like padded mattresses, patients still um, patients still have problems that occur frequently. Massage is physiologically plausible, but and it may improve circulation and tissue integrity, but it's not the most effective way because those injuries still occur regularly. And there has been promising studies that have showed that lower pressure injuries onset can be delayed. And what is not known is that the uncertainty of RCT findings apply across all ICU population settings and risk groups, whether they are across all ICUs. Also, limited evidence um, in hemodynamically unstable patients, fragile skin, patients with fragile skin edema, or patients on vasopressors. More studies are needed in that, and we don't know what the optimal technique is. Unclear on the ideal duration, timeframes, and frequency of the pressure areas to target, just to be able to avoid, and the role of other barriers, and then implementation feasibility. So we're uncertain about what is required on a unit to unit basis in terms of staffing and the training of nurses. Just I'll also be able to work that into the cost effectiveness and the workflow of the unit itself.
Hi everyone, my name is Jennifer, and this is the Iowa model, which is specifically designed for organization level changes. So, our trigger was a problem focused trigger, which is the continued development of pressure injuries in critically ill ICU patients despite current preventative measures. We used our picket question to guide the process, and from there, the model asked whether this issue is a priority for the organization. And according to the data summarized earlier, pressure injuries cause significant pain. They can increase the risk of infection, lengthen stay, and can cost anywhere around between 21,000 and 152,000 per case. Because ICU patients are especially vulnerable, preventing pressure injuries clearly aligns with the hospital safety priorities. Following the Iowa model, we then developed an interprofessional team to gather and appraise evidence. Our team structure included two ICU charge nurses as the primary appraisers and one wound care nurse as the third appraiser. This aligns with the Iowa model recommendations because it reduces bias, it improves reliability, and it ensures clinical and specialty expertise. Next, the model asks whether the evidence is sufficient to support the change in practice. Based on the studies presented earlier, especially the randomized control trial showing a decreased incidence and delayed onset pressure injuries, our team determined that there is sufficient evidence to move forward. Step 5 is to pilot the change. We selected the medical ICU as a pilot location. During the pilot, nurses will provide 15-minute effleurage massages twice on a daily basis as an addition to the standard pressure injury preventing measures. We will track pressure injury incidence and patient outcomes throughout this period. Step 6 involves evaluating structure, process, and outcome data. Structure evaluation includes reviewing staffing, resources, and equipment needed to support the intervention. Process evaluation includes monitoring adherence to the twice daily massage protocol, and outcome evaluation focuses on changes in pressure in injury incidence, severity, and the timing of onset. Finally, step 7 of the Iowa model is disseminating the results. We plan to share findings with ICU staff, nursing leadership, hospital administration throughout the unit meetings and presentations. And then, if the pilot is successful, results will expand or support the expansion of this practice to other ICU units. So now I'll move to the readiness assessment for implementing this change at Arrowhead Regional Medical Center. Arrowhead is a level 1 trauma center with high acuity ICU patients, which makes pressure injury prevention a critical focus. The hospital has wound care nurses available for expertise and training, which supports successful implementation. Leadership support is strong. ICU managers and charge nurses prioritize patient safety and evidence based practices, and the organization has a history of successful quality improvement initiatives. The organizational culture supports innovation, and the staff already has expertise with pressure injury prevention, making them likely to be receptive to a safe, non invasive intervention like effleurage massages. The In terms of resources, staffing levels are adequate, the equipment needed is minimal, and the intervention requires only a small workflow adjustment. Potential barriers include high patient acuity, being unfamiliar with the technique, and time constraints. However, these can be addressed with brief education sessions, hands on demonstrations, and incorporating the protocol into existing routines. Overall, the hospital demonstrates high readiness to pilot this intervention, and the Iowa model provides a structure framework to support successful implementation and evaluation.
On this slide, I will talk about what education we can provide. So for the nursing personnel, we will begin by reviewing the evidence from the randomized control trial, which supports effleurage massage as an effective adjunct to pressure injury prevention. We would explain the physiologic benefits, especially how light rhythmic effleurage helps improving microcirculation, increase tissue perfusion, and potentially lower the risk of pressure injuries in our critical ill ICU patient. Next, we will provide hands-on skill training. This includes demonstration and return demonstrations of the proper effleurage technique, the appropriate pressure to use, and the recommended frequency and duration. We will also review contraindications, such as open wounds, unstable fractures, severe edema, or significant hemodynamic instability, so nurses are able to identify when massage is not safe. To support workflow integration, we will teach staff how to incorporate the effort into routine care, such as during reposition, bed baths, and skin assessments. We will also provide documentation training, which include charting the site massaged, duration, patient response, and the changes in skin integrity. We will emphasize that this is an adjunct intervention designed to complement, not to replace current pressure injury prevention practices. For other health professionals, we will offer short in-service session for RT, PT, OT, wound care specialist, and a provider to explain the evidence and the expected outcomes. Their role is important in identifying very high-risk patients, especially those with low Braden scores or limited mobility. We will encourage open communication among discipline about skin integrity concerns and any contraindications to massage. We should ensure providers understand the intervention so they can support others, reinforce education with families, and advocate for continuity of the protocol. Wound care specialist will also be included in evaluating technique and monitoring outcomes as the practice is adopted. On this slide, I will focus on the education plan for administration and the organizational support needed to make this practice change successful. So for administration, we will present a concise summary of the research evidence showing how effort massage may reduce both the incidence and the severity of pressure injuries. A key point for leadership is that this intervention is extremely low cost, low risk, and requires no additional equipment, which makes it highly feasible. We will highlight the potential financial benefits as well, such as reduced length of stay and the lower cost associated with treating advanced pressure injuries. We will also show how these interventions aligns with organizational goals, including reducing hospital-acquired pressure injuries, meeting patient safety goals, and supporting magnet and quality improvement benchmarks. We will outline measurable outcomes like PI incidence rates, patient comfort scores, and staff compliance to demonstrate how progress could be tracked over time. In terms of support needed from leadership, we would request approval for staff training time, access to an educator for ongoing support, and updates to EHR documentation so that effort can be charted consistently. We will also propose developing a standardized protocol to guide the practice. Ongoing monitoring, such as monthly data review, staff feedback, and quality reporting, would help maintain the intervention's sustainability. We will also encourage a culture that values evidence-based practice and innovation. Overall, the goal of this education plan is to ensure that every level of staff, from bedside nurses to administrators, understand not only the rationale behind the intervention, but also how to implement it safely, document it correctly, and integrate it smoothly into existing ICU workflows.
So the following is a proposed ICU protocol intervention scenario. Effleurage massage to the sacral region and major pressure areas twice daily for 10 to 15 minutes. And you do this using gentle, non-friction technique. And keep in mind the Braden score. So we want to prevent pressure injuries and go in coordination with the unit and get it approved. And then patients eligible for this are immobile ICU patients who are expected to remain more than 48 hours within the unit, and then who have a Braden score of less than 18. And then intact skin without open pressure injury at the site are the criteria to be included. And then what's excluded is deep tissue injuries that are already present and severe thrombocytopenia or other coagulation issues and uncontrolled hemodynamic instability, because those will produce unreliable um, results, and we can't factor in those conditions into the overall um, implementation and um, of the technique. And then patients who already have other skin tears or burns or a device related to wounds um, at planned sites. And then we would document this and then see how the patients tolerated the procedures, the interventions, the skin changes that occurred over time, and then the site and duration and the massage technique, and how often it was applied, obviously. And then the quality of the monitoring will be weekly skin audits, and then complete pilot rooms versus standard care. So the difference between the control group. And then finally, uh, pilot and evaluation. Phase one will be 8 weeks, and we start in the one ICU pod, and then monitor the patients and see how they responded to the safety measures and how they complied to the overall treatment, and how we can expand that. And that will be phase two. And if we see positive results, we are able to expand it in a safe and effective manner to the rest of the unit, and see how those techniques helped improve the overall safety of the patient and cut down on pressure injuries.
To conclude, for the question posed to our classmates to be discussed in the discussion board, as a group we collaborated and decided to ask, if you were caring for patients in the ICU, based on the research presented in this presentation, would you incorporate the effleurage massage technique with standard pressure injury prevention methods into your plan of care? Why or why not? So we just want to set out to see how you would basically, and if you would, implement this in your plan of care, and how you would do it, how you would find the time, and just give us your assessment into how this can improve your patient's care plan. Thank you.
Here are the references we used during our presentation. Thank you for watching. We're happy to answer any questions.